It's my pleasure now to introduce you to Dr. Theodore Welling, who is here to share with us the latest advances in liver cancer immunotherapy. Dr. Welling is the director of the Liver Cancer Program and leader of liver cancer immuno-oncology and clinical trials at the Perlmutter Cancer Center at NYU Langone Health in New York City. There, he brings a multidisciplinary approach to treating patients with liver, pancreatic, and bile duct cancers and conducts translational and clinical research aimed at improving outcomes for patients with these cancers. During Dr. Welling's presentation, don't forget to submit your questions in the Q&A box. Brian Brewer from the Cancer Research Institute will be watching for them. I'll now turn it over to Dr. Welling and Brian to get the most up-to-date information on immunotherapy for liver and related cancers.
Thank you for that kind introduction, and I'm glad to be here to talk about liver cancer. Just first of all, to put things in perspective, when we talk about liver cancer, we're talking about the most common type of liver cancer, which is hepatocellular carcinoma, which is the most common type, and then cholangiocarcinoma, which is the second most common type of primary liver cancer. The other liver cancers that are listed here, hepatoblastoma and fibrolamellar hepatocellular carcinoma, are less common and more commonly found in children or in young people. But for the purposes of our discussion today, we'll be focusing primarily on HCC and cholangiocarcinoma. The most common risk factor for hepatocellular carcinoma is viral hepatitis, and the most important or strong risk factor in that category is hepatitis B. As an important reminder, hepatitis B can be prevented by vaccines against hepatitis B, and we know that people who have chronic hepatitis B are at the highest risk for developing hepatocellular carcinoma. We also have other treatments for other viral hepatitis, such as hepatitis C, which can also lower the risk for hepatocellular carcinoma if people are treated for chronic hepatitis C. And so when we talk about immunotherapies for liver cancer, this is primarily in the setting of what we call advanced disease. So these are in patients who are not eligible for surgical resection, as an example, or are not eligible for other what we call directed or local regional therapies. And then we have to think about systemic therapies for cases of more advanced disease. Now, some of these are in the process of being studied in combination with local regional therapies as part of clinical trials, but these are approved drugs at this moment for patients with more advanced disease, either hepatocellular carcinoma or cholangiocarcinoma. These primarily, from an immune modulatory standpoint, target what we call checkpoint molecules in the immune pathways. So they essentially inhibit inhibitor molecules to essentially ramp up the immune system to more vigorously attack the tumors. And so what you see here is, importantly, the most common or first line drug is a drug known as atezolizumab, used in combination with bevacizumab for advanced hepatocellular carcinoma. We also have now recently indicated durvalumab, which targets PD-1 ligand in cholangiocarcinoma, and that's used in combination with standard chemotherapy agents such as gemcitabine and cisplatin in cholangiocarcinoma. And that's now approved as first line. There are other drugs listed here, ipilimumab, nivolumab, and pembrolizumab, which also target checkpoint inhibitors. And currently those are indicated as second line indications, or in some cases are still being studied in other combination regimens with other targeted agents. On the right side here, you can see other targeted inhibitors. Some of these were previously approved as first line, but are currently being studied in other combination regimens with immunomodulators. So, for example, lenvatinib as well as sorafenib were previously indicated as first-line treatments in many patients with hepatocellular carcinoma, but are certainly still indicated for patients that are possibly not eligible for immunomodulatory agents or used in the second line setting. These are, as I said, still being studied in other combinations similar to bevacizumab, which is currently used in combination with atezolizumab. And so other trials are ongoing to look at the right combinations of these agents with immunomodulator agents.
Thank you very much, Dr. Welling, for that introduction on immunotherapy for liver cancer. Sounds like there has been some progress there. This is a disease that a lot of us have encountered in our lives or in our families, and it's wonderful to know that immunotherapy seems to have some effect in these patients, either alone or in combination with chemotherapy or some of those other targeted therapies that you mentioned. So before I go into it here, I just want to encourage all of you who are watching to please take advantage of that Q&A box on your screen and type some questions into that box. We'll try to get those questions to Dr. Welling to answer them, and we'll go as quickly as possible with that. So hopefully we can get to everyone. And for those of you who submitted your questions in advance, thank you. We have those as well. All right, so let's go ahead and start with immunotherapy for different stages of cancer. If someone is diagnosed, this is not from the audience, by the way. If someone's diagnosed with stage 1 or stage 2 liver cancer, is immunotherapy an option for them, or is there another way to treat this?
Currently, immunotherapy is not an option in that we have other treatment options at that point for stage 1 and stage 2 disease, such as surgery or other what we would call ablative therapies. Many of these can have the potential of being curative. And so while it will be studied ongoing in the future, currently the main recommendation is for what we call directed therapies for these stage 1 and stage 2 disease levels of disease.
What is a directed therapy?
So directed therapy would be surgical excision or resection, or in some cases ablation, and that can be done a couple of different ways, either percutaneously or through a process known as radioembolization, which is catheter-directed embolization, or even chemoembolization, are all treatment modalities that could provide a therapeutic benefit and a survival benefit.
So resection equals surgery, and ablation equals burning, right? Generally, just trying to put it in terms that our audience will understand.
Sure. Ablation is done sometimes during surgery, or it's done through our interventional radiology techniques. So it's done percutaneously in an image-guided manner. Those are what we call ablative techniques when we're so-called burning the tissue, if you will, or heating the tissue. And there's different technologies to do that.
I see. We do have a question about the causes of liver cancer. And I know you mentioned one of the risk factors is HBV virus. So obviously the question is liver cancer only caused by alcohol? Apparently not. But I'm wondering, is there a difference in response to immunotherapy based on how we think the cancer might have arisen? Is there a greater chance that those that have liver cancer from the virus more likely to respond to immunotherapy than those who develop it after cirrhosis of the liver?
So there are different risk factors for liver cancer. Certainly, anyone who has cirrhosis is at risk for developing liver cancer, no matter what the cause of the cirrhosis. We have evidence that people who don't necessarily have cirrhosis are at risk. So, for example, patients with chronic hepatitis B without cirrhosis are at risk for developing liver cancer, as are people who have what we call non-alcoholic steatohepatitis. So in many cases, even if they don't have cirrhosis yet, they are still at risk for developing hepatocellular carcinoma. It's still being studied whether some of these disease etiologies are more or less responsive to immunotherapy. We still do not have a clear understanding of that yet, but based on the current data, it seems that all people or all patients with these different etiologies could benefit from immunotherapy if they have advanced hepatocellular carcinoma.
See, that's a nice segue actually to the next question. Again, about the causes. Is liver cancer hereditary, or can it be hereditary?
There's no clear hereditary disposition to hepatocellular carcinoma. There are some cancer syndromes, and by that I mean GI cancer syndromes, where cholangiocarcinoma can seemingly be associated with some of these syndromes. But for the most part, for hepatocellular carcinoma, 90% of cases are associated with some degree of liver dysfunction, cirrhosis being the most common. There are about 10% of cases, though, that arise sporadically where we do not have a clear understanding of an underlying risk factor or etiology.
You mentioned just now cholangiocarcinoma, and I recall from your presentation that's a cancer of the bile duct. Is that correct?
Yeah, so cholangiocarcinoma occurs in different locations anatomically. It's kind of lumped in under what we call biliary tract cancers, but the most common type that arises or arises in the setting of chronic liver disease is what we call intrahepatic cholangiocarcinoma. So these are the kind of mass forming types of cholangiocarcinomas that occur within the liver. Cholangiocarcinoma can also affect the main bile ducts, though, and these can cause obstructive symptoms of the bile duct system. Can be high up in the bile duct system, or it can be lower down in the bile duct system towards the end of the bile duct, even involving near the head of the pancreas.
Here's an interesting question. My mother has Lynch syndrome and has had colorectal cancer, but I see that, or I hear that Lynch syndrome can also cause cancers of the liver or other places around there. Am I at risk for any of these cancers? Should I have my liver looked at? Let's start by saying what is Lynch syndrome, and what connection, if any, does it have to liver cancer?
Well, Lynch syndrome is, essentially a syndrome where you're at predisposition for GI cancers, most importantly colorectal cancer, but other GI tract cancers can appear in that syndrome. Cholangiocarcinoma is still a rare enough cancer, even in the setting of Lynch syndrome, that there's no clear prospective screening guidelines, other than certainly if there are any suspicious lesions that are identified either within the pancreas or within the biliary tree, we certainly have a much lower threshold to act on them, or at least do a deeper investigation given the predisposition to GI cancers.
I guess really quickly, what are some of the symptoms of this? How would someone know to look for lesions?
Well, that's the tough part is that we don't have great screening tools for a lot of the population. All we can do is identify risk factors for these diseases. Many people do not have any symptoms when they develop liver cancer, whether it be HCC or cholangiocarcinoma. There are some patients that will have worsening of liver function for unclear reasons, and that can be their presentation of liver cancer, or they might develop jaundice, in more rare circumstances, pain. But the vast majority of patients do not have any symptoms whatsoever. And that's why we're always trying to identify at-risk populations to properly screen patients.
Okay. Here's a question from an audience member. I've heard the term complete response and partial response. What does that mean in terms of liver cancer and immunotherapy?
So the response is really based upon the radiographic impression. And so a complete response is essentially we see no evidence of tumor tissue remaining on radiographic examination. So this is, of course, the best response that we can hope for and the best response that we're ultimately aiming for when we look at therapies or medications for these types of cancers. A partial response is in between that. So by strict criteria that we use in the research field, this means that there's at least a reduction of the index tumor size by 30% or more. So not 100% to meet the criteria for complete response, but certainly a significant reduction of the tumor size. And based on the evidence that we have for at least immunotherapy in the setting of liver cancer, we know that patients that have a partial response seem to have a longer survival benefit with regard to these agents.
Is that different from responses to chemotherapy? And if so, how?
Well, typical chemotherapy agents have not worked well over the years with respect to hepatocellular carcinoma, so it's very difficult to compare. But we do know that when we have a response with immunotherapy, that translates into a survival benefit. Cholangiocarcinoma, we are able to see responses with what we would call standard chemotherapy regimens, but those response rates are actually increased in the setting of immunotherapy for some patients, and certainly that does seem to translate into also a survival benefit with these agents.
Thank you. We have another question from the audience. I hear about genetic tests for breast cancer and other types of cancers. Do I need to get one for my liver cancer? Do I need to ask my doctor for that, or will he do it? And do I need to travel to a city to have that done?
So increasingly, we are doing genetic testing of tumor tissue for liver cancer. It's a little bit less clear of whether that should be done as a standard maneuver with regard to hepatocellular carcinoma, but we increasingly are doing that as part of the standard of care for situations where if patients are resistant or refractory to our standard first line and second line therapies. That is clearly the standard of care for cholangiocarcinoma. So when we get a tissue biopsy to confirm the type of cancer and getting ready to initiate treatment, particularly for cases of advanced disease, it's important to confirm with tissue testing. And for cholangiocarcinoma, we can sometimes identify driver mutations for which patients may be eligible for unique treatments following what we call first line regimens if they either start to become less responsive to that therapy or resistant to that therapy.
Is there any correlation between the presence of certain markers and outcomes for liver cancer patients receiving immunotherapy?
Right now, that there's not a clear predisposition. There are a lot of common mutations identified within hepatocellular carcinoma, but as of yet, there's no clear route to benefit over us. For example, with cholangiocarcinoma, the same is true. There's deep enough study yet to identify patients that are clearly of higher likelihood to benefit versus those that are less.
Okay. Let's see, another question from the audience here. Thank you all. And if you haven't submitted a question yet, if you have a question for Dr. Welling, please type it into the Q&A box. We'd love to hear from you. Let's see. My liver cancer hasn't spread to the lymph nodes or other organs. My doctors say they can't operate on it safely and have suggested different options, including immunotherapy. Can I do more than one option, or do I have to choose? And if so, how do I choose?
So it really depends on the degree of tumor burden and how extensive the liver tumor burden is. There are situations where the cancer is not operable, meaning not able to be safely resected, where we're able to do some of these other therapies we talked about earlier, what we call local regional therapies. And so these are therapies that may not necessarily offer the chance for cure, but they can certainly offer what we call significant treatment benefit or survival benefit, and can be done safely depending on the person's level of liver function and overall tumor burden. However, if the tumor burden is quite extensive, or we're more in the setting of what we call advanced disease, then these systemic therapies that we talked about are more appropriate to use. And the idea is that you can treat the tumors wherever they may be, meaning if they're in several areas of the liver or even potentially other areas in the body, then these systemic therapies allow treatment of wherever that tissue may be.
How is maybe we can just talk briefly about how immunotherapy is a systemic treatment and how it works throughout the entire body. Why is it if I have a tumor in my liver and then it's spread, how can immunotherapy get to all those places?
Well, immunotherapy acts really indirectly on the immune system. So the immune system is made up of essentially white blood cells which circulate around the body, and they interact with all sorts of tissues in the body, including tumor tissue, wherever it may be. So when we have any situation where there's advanced cancer, or certainly cancer in multiple locations in the body, that's where chemotherapies or immunotherapies are considered, because it allows treatment of the cancer wherever it may be, whether that means directly acting on the cancer cells themselves by attacking the cancer cells, or in the case of immunotherapy, acting on cells that are nearby, in this case, the system that can be reiterated to attack the tumor cells more vigorously and kill the tumor cells.
I see. And if any of you are watching this webinar and happen to miss our basics on cancer immunology and immunotherapy, which was part of our day one program, strongly encourage you to check that out and learn a little bit more about how that works. We have another question. Actually, I've seen this question come through some of our other segments as part of this program. I've already received immunotherapy for liver cancer and it didn't work. Does that mean I can't get any more immunotherapy, or might another one work? Am I out of options there?
Well, there are other therapies, what we call other targeted therapies. So these are therapies essentially going after growth factors and receptors that are very active in the liver cancer, and also in the surrounding blood vessels that help supply the tumor. So there is a variety of agents that are approved to use in order to increase survival and treat the tumor tissue. There are increasingly clinical trials that are examining other immune therapy agents, either in combination with other immune therapies, or in some cases in combination with some of these other already approved targeted agents. And so there are many trials in the pipeline and new drugs in the pipeline. And some of these are actively enrolling in some centers across the U.S.
Any that are particularly exciting from your perspective?
Well, I think there are other checkpoint inhibitors that can be combined. And what we're seeing so far is that in some cases those can double the response rate. And so I think that's probably the area under the most active investigation. So essentially targeting two different molecules in the immune checkpoint pathway, for example, seems to have a potential additive effect.
That's really good to hear. Here's a question from another audience member. Immunotherapy isn't working for me. Why does it help some patients but not others?
Well, that's a thing that we're still investigating, and it may be that while immunotherapy may not cause a response, There are some patients who have what we call stabilization of disease, meaning disease isn't necessarily shrinking, but it may not be growing either. And so it depends on what we describe as working. And so in those cases, immunotherapy could be well tolerated. And if the disease is under control, patients can still benefit from that treatment. Sorry, I can't hear your question.
The muting. Okay. So we've heard about from many others who've been to this program, and earlier today, as part of our basics of immunotherapy, we heard about side effects. And I'm wondering, are there, obviously there are general side effects that seem to apply across all types of cancers when patients are receiving immunotherapy. Are there any particular side effects that affect patients with liver cancer or any of these other cancers that you are looking at?
So the good news for these types of regimens is that generally they are a bit better tolerated than some of the more traditional chemotherapy regimens. That's not to say that they don't have side effects, however. And so probably the most important thing is looking for what we call off-target immune-related side effects. So the oncologist will look through a combination of signs and symptoms and physical exam, but also blood tests to make sure there is no off-target side effects. And probably the most important thing is looking at things such as liver function, because there can be rare hepatitis or what we call immune-related hepatitis as a side effect. And when you already have a liver that's diseased and then also burdened with liver cancer, it's important to keep an eye on that. And so those blood tests are done fairly regularly as part of the treatment regimen.
Are these tests and other if you are, for instance, not in a clinical trial and you're receiving immunotherapy, obviously there are part of that that's just part of the standard of care. How different is that from the level of care one might receive, or the number of blood tests, for instance, if one were participating in a clinical trial?
It's probably a little bit less frequent. It depends on the type of clinical trial. So there are certain what we call phase 1 clinical trials where the testing and investigation or safety measures are certainly more frequent because there's less experience with the drug. However, for drugs that are already approved, or certainly in the phase 3 setting, the level of testing is less. It's not zero. It still needs to be done as part of safety for giving any of these medications as part of the standard of care. And so that's something that the oncologist will do, is routinely test for some of these things that for which side effects could manifest.
All right, thank you for that. The next question I have from one of our audience members is, I was receiving checkpoint inhibitor for liver cancer. I had to stop treatment due to side effects. Is my immune system still fighting cancer after I stop treatment?
It's difficult to say. We know that the immune system is still always in a constant battle to some degree or another with the tumor. But we know that when people come off therapy or come off their immune modulator, that the half-life of the drug or the effect on the immune system certainly starts to go down over a period of a few weeks. So it's in terms of lasting effect of the drug, it's probably unlikely, but the natural immune response that your immune system is having may still be there.
Okay. We're almost out of time, and before we go, I'm very curious to get your thoughts on how treating liver cancer today is different from how it was when you first started or first getting into this work. Can you say a few words about that and how has your perspective changed? Is your outlook different? Are you more optimistic?
Yeah, I would say we're overall much more optimistic than we were several years ago. When I first started, we had essentially only one drug, which did not work very well. Now we have many drugs that are approved for various circumstances, and it allows a lot more investigation and innovation to see how these drugs may combine. And there's many other drugs, of course, being developed. So it is a very, very robust and active research time, but at the same time, we have a lot more tools to use as well.
That's good news for anyone who faces a cancer diagnosis, and also those, of course, with liver cancer and the other cancers we discussed today. Dr. Welling, I want to thank you so much for taking time, spending time with us today to get this important information to our audiences. And I also would like to thank the Perlmutter Cancer Center at NYU Langone for being one of our hosts and helping us make this program possible. So thank you again very much, and we look forward to hearing about more progress in the future in liver cancer.
Thank you.